on the topic of impact of expectation in healthcare. We are very honored by the presence of distinguished international experts who will contribute to this stimulating and timely scientific program. As a neurobiologist and professor of pharmacology, I have always been fascinated by the mechanisms underlying the effect of expectation and reward and the relevance to the placebo effect. Especially upon reading years ago, I was not even a PhD student, the article of Gracely et al. Published in the first issue of Lancet, showing that the clinicians' own expectations shape the placebo response in their patients. I will come back to this issue of expectation and reward. However, I would like, first of all, to point out that the chair of complementary and integrative medicine at the University of Zurich is the first of its kind in Switzerland. It was initially created in 1994 as chair of naturopathy, Naturheilkunde in German. Professor Reinhard Saller was the first holder of this chair. With the appointment of Professor Claudia Witt almost 3 years ago, it was renamed to its current designation, which more appropriately defines its scope and purpose. So I'm very pleased that we are here today to hear about recent developments of prime relevance for the research activity at the Institute. Next, let me mention that in Switzerland, complementary medicine has an important political dimension. This is linked to the direct democracy procedures that are in place in this country. In 2009, 2/3 of Swiss voters approved a referendum to introduce a new article in the Constitution, giving due consideration to complementary medicine. Since then, not only are anthroposophic medicine, homeopathy, phytotherapy, and non-acupuncture traditional Chinese medicine covered by mandatory health insurance as long as they are practiced by certified doctors. But also, complementary and integrative medicine are integral part of the curriculum of human medicine. This topic continues to be an important subject of discussion because it was decided that complementary medicine will be covered by health insurance until the end of 2017, while its effectiveness is being evaluated. After this date, so in a year from now, it will be determined whether state coverage should be made permanent or not. Although the University of Zurich proudly belongs to the League of European Research Universities, LERU, and strives to enhance its ranking among Europe's top universities, especially in the fields of life science and medicine, there is no contradiction with maintaining and further developing a chair of complementary and integrative medicine. Quite the contrary, considering the breadth and importance of research that will be presented and discussed here today. As Vice Dean for Research, I still would like to make a short statement and give you an example of research that has very deeply impressed me about the effect of expectation and placebo. Experimentally, it is not easy to study these topics in animals as they are inherently subjective experience. In my view, however, an interesting approach was developed by Professor Ranulfo Romo, a neurobiologist working at the National Autonomous University at Mexico City. His research in primates aims to elucidate how sensory perceptions give rise to decision processes and activate motor circuits in the brain. He trains monkeys to detect vibrotactile stimuli on the tip of the fingers and use this perception to make the decision, communicated after a fixed delay by a defined movement of the arm. I detected it, I did not detect it. Monkeys learn this task very rapidly and happily perform it for hours, provided that they are rewarded after each correct decision. In order to introduce a degree of subjectivity in the process, Ranulfo Romo then decided to use subliminal stimuli delivered at such low amplitude that they become barely perceptible at best, while still giving the cue for the monkey to signal the decision. The uncertainty associated with imperceptible stimuli forces the animal to use internally generated subjective perception to make the decision. Romo observed that this paradigm strongly activates the dopaminergic system and causes visible relief of the animal upon each correct decision. Whereas detectable stimuli cause no extra dopamine release. His research revealed that dopaminergic neurons code subjective sensory experience and uncertainty arising internally from perceptual decisions, very much in line with the role of dopamine in mediating the placebo effect, for example, in patients with Parkinson's disease. This example shows the relevance of basic research in this field and its applicability in clinical settings. The Faculty of Medicine takes its duty to promote research very seriously and is strongly committed to enhance the involvement of clinicians in research. Thus, the faculty has launched 3 years ago a successful program called Filling the Gap, which aims at financing protected research time for clinicians, especially women, in order to advance the career and enhance their chances to succeed in academia. Recently, a group of faculty members, including Professor Claudia Witt, also conceived a clinical PhD program, which provides graduates in medicine with means to engage in scientific research in the clinical setting, and which we have launched a few months ago in the hope to strengthen research in all clinics and hospital departments. To conclude this welcome speech, I wish all the participants of this symposium a very fruitful afternoon, and to our guests from abroad, thank you for coming and have a pleasant stay in Zurich. Thank you.
Thank you very much, Jean-Marc, for the opening speech and a little bit introduction into our faculty. The warm welcome also from my side. My name is Claudia Witt. I will be your today's moderator, and I warmly welcome to the third symposium. We do an annual symposium, and this time we have really chosen the topic placebo and nocebo because it's something which we very often experience also in our daily practice, but which has a huge impact on medical care overall. And we have taken one detail out of it, which is expectation. And we have international experts really showing the different angles of expectation. So you will hear an overview, you will hear about research. But unfortunately, I have also to announce that Peter Krummenacher, who wanted really to show us his research from neuroimaging, he gave me yesterday night the information that he has a bad flu, so he's lying with very high fever in bed, apologizing for this. But he gave me his slides, so we will also upload the slides of his presentation. One information is important because we record the whole sessions, and you should really feel free to discuss, so don't be shy. We cut off all the discussion section. And it will be only the talks which we will put up in the internet for those who want to see it a second time or those who were not able to be here. I also welcome my students from the placebo-nocebo group who have this symposium also as one part of their training. So, thanks again, Jean-Marc, for being here and opening this one. And we will move to the first speech. And it's a great pleasure for me to welcome Paul Diep. Paul Diep, I can say it's now Professor Emeritus from the Exeter Medical School, but Paul has very deep roots in rheumatology. He has published in the British Medical Journal over the topic placebo and nocebo, and he will give us insights into expectations, placebos, and healing responses. Please welcome with me Paul Diep.
Thank you very much, Claudia, and lovely to see so many people here. Claudia told me this would be quite small. I think this is quite large and just a little bit nerve-wracking. It is really a wonderful pleasure and honor to be back here in Zurich. And I am an emeritus professor now, which means I'm a retired old fart, really. But one of the great pleasures that I still have in my part-time working life is being able to visit centres like this and to interact with some of my heroes in the field, of whom Claudia Witt is definitely one. I think the work you've done in this area of CAM and integrative medicine over many years, Claudia, is fantastic. And thank you for allowing me to have some little role in this through today and tomorrow. Thank you. So, that's my title, and I'm not sure how all that fits together, but we'll see. So I'm going to actually talk about 5 topics, which is a bit ambitious in the time allowed, but we'll see how we go. So just a brief introduction to some of my thoughts about expectations. Then I want to go back to my rheumatology days and talk about joint replacement. And then go on to some of the things I'm working on at the moment, which include issues like safety and validation, and then see a little bit about how this might all tie in with placebo and healing. So that's where I'm going. So we'll start with expectations. And expectations, as we've just heard from the introduction, are very important. They change outcomes. There's a massive body of work on this. Just 2 examples. If you are given a cup of coffee and you're told it's got caffeine in it, you will have a physiological response with raised heart rate and all the rest of it, as well as the psychological effects of increased attention and anxiety and all the rest, even if it's got no caffeine in it, as long as you're told it's got caffeine in it. Loads of experiments to show that sort of phenomenon. And on the other side of it, in the nocebo, perhaps some of the best examples is from trials. If we warn people in trials that side effects may occur, quite a lot of the people who've got the dummy tablet, the tablet with no active ingredient, will get those same side effects. So they've been told to expect the side effects, so they get them. So these are powerful effects. They're reproducible. Many, many experiments have shown that they occur. And the implications of this, I think, both for clinical work and for our research are huge. So when we're doing clinical work, what we tell our patients to expect, how we deal with the expectations they may have picked up from the internet or from talking to friends, all of these things are potentially going to be very important. And in our research, we have to think about how we, for example, consent people to trials. I think this is an unexplored area that really needs attention. What is the effect of the consent form? What effect does it have on expectations and therefore on what happens in the trial? So expectations, very big effects, very important in medicine and in medical research. So far, so good. But what actually is an expectation? Well, it's defined, and this is a definition from a dictionary, as a belief that something is likely to happen in the future. And of course, we all have lots of beliefs, lots and lots of beliefs about what's going to happen in the future, and they're actually part of who we are. They're part of our identity, and they're how we make sense of the world. And within that, and within areas like health, we actually have a magnitude of different ones. Some of them are big ones, and some of them are little ones, and they potentially compete with each other in the way we run our lives. So just for example, big beliefs and little beliefs in health, you might have the big belief that it's all God's will, whether you're going to be ill or not, and what's going to happen in terms of the outcome is dictated by God. That might be a high-level belief. But underneath that, you might have a little belief that actually I think, I might do better if the doctor gave me herbal remedies rather than these drugs. That would be a little belief below it. And the little belief is definitely relational in that it depends on the interaction with other people around you, and it can be changed. So it's not a belief about, you don't have a single belief about whether you're going to get better or not or what's going to happen. You have a multitude of different beliefs which are hierarchical, and some sit above others. And only some of them, I think, are easily changed in relations. So expectation is not a simple construct. So we've managed to get through part 1 quite quickly, so I think we'll be all right. So I'm moving to joint replacement now. You might wonder why, but we're moving to joint replacement because I've spent an absurd amount of my research career on researching joint replacement. And inevitably part of that research has been about expectations. So I just want to tell you a bit about that, just to indicate again some of the complexities around this issue of expectations. So joint replacement, good treatment for people with advanced joint disease, advanced osteoarthritis. Usually held up to be one of the best, most cost-effective interventions that we have in modern medicine. But it doesn't work all the time. It works well for most people, but about 10% of people who have a hip replacement, and actually more than 20% of people who have a knee replacement, do badly. They're either not much better or, in some cases, worse than they were before they had the joint replacement. The references here are from the team I've worked with, but there's masses of publications to show that phenomenology of joint replacement. And high expectations, or what's sometimes in this area called optimism about the outcome, are clearly associated with better results in this spread of outcomes after you've had a joint replacement. Andy Judge did that work with my group, but again, several other people have shown that. So if you get a questionnaire asking people about their expectations before they have the joint replacement, and you relate that to how they did a year later, you get a clear relationship with better outcomes for high expectations. It fits with all the other literature about expectations that we've mentioned already. But what happens if you then go and look qualitatively at what's going on? And this is confined to the UK. The UK, I need to remind you, is a small island near Europe. And probably doesn't represent anything really apart from idiotic approach to Europe. But anyway, in the UK, for what it's worth, many orthopedic surgeons, when they're talking to patients, they actively try to reduce expectations. They say things like, and these are quotes, "It's not going to be perfect, it's not going to make you 21 again." They try and lower the expectations because they believe that high expectations leads to dissatisfaction with the outcome. And again, a quote, "Well, of course he's not happy about the operation. He hoped that it would turn him into a great golfer." And these are quotes from work of Anna Sansom using qualitative research with surgeons. So in the surgical community, there's a sense that high expectations are a bad thing because it'll never be met, and it leads to dissatisfaction. No evidence that that's true, but that's how they work, and they try to lower expectations, many of them, before the operation. Well, that's quite interesting, but it's not nearly as interesting as what happens if you do qualitative work with the patients. So we asked people on the waiting list to have joint replacement how they thought they would be after the operation. That's just a lay way, really, of saying what their expectations of outcomes were. And they didn't want to tell us. And here again are some quotes. This is work by Gillian Woolhead, who was one of my PhD students. "I don't know what to expect, to tell you the truth. I don't know. I don't like to think about that." Several people said that. I don't want to think about it. I don't know. Or, "I cannot say, that would be tempting fate, wouldn't it?" There was this sort of sense of, "Oh, don't do that to me. I don't know. I don't understand all this." So they didn't want to know. And this is by no means unique, this piece of research by Gillian. There's plenty of other papers around in surgical interventions, qualitative studies, that suggest that people cannot express prior outcome expectations. They talk instead about hopes and fears. "Well, I hope the pain will be a bit better, but I'm really worried that I'll get an infection." So they're balancing their hopes and fears in their conversations to you about expectations, and they're often frightened, anxious. Who wouldn't be? But interestingly, after the event, they can tell you what they were expecting. So they may say beforehand, "Oh, I don't know, I hope the pain will be better, but I'm worried about the infection." Afterwards, they'll say, "Well, I was pretty confident that the pain would get better, so I was happy to go ahead with it. It was all good, it's all fine." So there's a complete change of concept afterwards than there was before. But of course, what we do with most of our expectation research is not talk to people to understand where they are. What we do is we give them a questionnaire with a limited number of options about expectations. And, patients are brilliant. They fill in the forms, even if they think they're stupid forms. They give us an answer because we've asked them for one. There's, again, masses of research, qualitative research to show this. You give someone a questionnaire and they say, "Well, that's a very stupid question. How well am I? I don't know. Well, I'll tick this box, I suppose, because you want me to tick a box." This is work with the think aloud technique, where you give people questionnaires and you turn a recorder on and you ask them to tell you what they're thinking as they fill the questionnaires in. So I think a lot of our work on expectations is actually quite flawed, because it depends on giving people options within a written response which does not reflect really what they're thinking and what they're worrying about. Having said that, there are clearly some preoperative expectations and beliefs might be a better term for this, that are relational. In other words, they can change in relations and can be altered by healthcare consultations. And I want to give you one example of this, again from my work in the joint replacement field as a case study. So this actually was a professor of medicine, like me, a retired professor of medicine. We're all hopeless, aren't we? He came to see me with severe hip pain that was radiating down his thigh, and he was quite convinced that he had a terrible hip and that he needed a hip replacement. Hip osteoarthritis was in his family. His father had ended up in a wheelchair many years back before hip replacements was a standard option, and he thought that was going to happen to him, and he was frightened. But the examination and the x-rays of his hip were quite normal. So I examined him and I looked at his x-rays and things, and I thought, well, actually probably this is coming from the spine. He had some facet joint disease. Facet joint disease can radiate into the hip and thigh region, and that's what I told him. I said, look, I think it's coming from the spine, not the hip. And I vividly remember the first time I told him that. He was a professor of medicine, senior to me. I'd examined him carefully, looked at his x-rays, and said, look, it's your back, it's not your hip. He shouted at me, he said, that's ridiculous, you're completely wrong, you call yourself a rheumatologist, how dare you? And he stormed out of the room. And, but he came back to see me a couple of weeks later, by which time I'd got out some literature, old literature, to show that you could reproduce hip and thigh pain by injecting saline into a facet joint of the spine. So I was armed with some evidence of the sort that I thought he would approve of, rather than an idiotic young rheumatologist like me. And again, he wasn't convinced, but he took the papers away and said, well, he didn't really think I was right, but he'd have a look at this literature and he'd have a think about it. And he rang me up a week later, and he said, my pain has gone. He said, I read that stuff, I wasn't sure, but then I woke up the next day and I believed you, and the pain hasn't bothered me since. And I used to get a crate of wine from him quite regularly after that, which is probably why I remember the story. Although alternatively it would be a reason to forget it, wouldn't it really? But so that was a placebo effect, a rather startling placebo effect caused by altered expectations and beliefs. But it could only happen when he got to a point of he could trust and believe me and alter his belief accordingly. He had to be in the right place. There had to be trust. There had to be belief. And then he could have quite a massive change in what he thought about the world, and the placebo effect, getting rid of his pain, followed. Now, unfortunately, in my view, most of our research about placebo effect just concentrates on the patient's brain. So, with respect to some people in this audience, the neurobiologists and imagers would have scanned his brain and measured his dopamine, all that stuff. The thing that interests me is the relational bit. What was happening between him and me and his reading of the papers and understanding of the world? What was that about? How did that facilitate this change that then led to strange things happening in his brain that frankly don't interest me a great deal? So it's about changing expectations, and it's about trust and belief. We never trust a used car salesman, do we? But what about this person? Show of hands, how many people feel they could trust this lady? About half of you. I mean, not sure, are you? So not sure is a good response. And what about this one? It's difficult, isn't it? And it's because actually, you see, it's all about context. It's the context they're in. It's the trappings. It's, oh, I've done something terrible. I've probably ruined the whole day. Oh, no. I was looking for a pointer, but is this the, oh, gosh. Oh, that one. I want to use this. It's, I was just going to point out to his power symbol, you see. He's got his power symbol around his neck. and he's got his white coat. He's got his symbols on, symbols of power and authority, and it's all those sort of contextual issues and other stuff, as well as the cheesy smile and the rest, that might affect this issue of whether we trust people. The fact is, we make very rapid decisions about whether to trust our used car salesman or not. It's almost like that. As you walk in the room to have a consultation with somebody, the trust issue can be almost instantaneous. I have no idea how that works. I think it's really interesting. Highly context dependent and very individualized, I think. So I think the issue of why we put our trust in some people and not others, and why we let some people alter our beliefs and our expectations, is a really interesting issue around this topic, and really relevant to whether we're going to get these massive placebo effects or nocebo effects or whatever. And I think it's really complex. It's clearly context dependent, and I don't think we know much about it. But we have been working on one relatively simple biological mechanism that might help us here in our ability to help people with their expectations, and that's the polyvagal theory. I'm going to be boring and just ask for another show of hands. How many people here know about the polyvagal theory? Okay, I see 1, 2, 3, 4 hands. That encourages me. Well, actually, it discourages me. You should all know about the polyvagal theory. Why doesn't everybody know about the polyvagal theory, for goodness sake? It's been around for a long time, but it's always the same. Nobody's ever heard of it. It really gets to me, this, you know. I don't know what Stephen Porges thinks. I can't imagine, because he's the guy who actually developed this theory many years ago, and I think it's a game changer. So it's about safety and validation. So what does this picture make you feel like? Don't write your answers on a postcard. Shout them out. How does it make you feel? Joyful, cozy, good, yeah? Safe, perhaps even? Yes, it produces a nice relaxation response in us as human beings. And there's a very good physiological reason for that. So we all know about the fight or flight response, or its extreme end of the scale, where you shut down completely. Response largely sympathetic driven within the autonomic nervous system. And that's a preservation response. But we also have the opposite built into us as higher animals, another system that's just about the complete opposite of the fight or flight, that allows us to work in groups and to nurture our young, which take a long time to mature. In the case of my own children, some 40 years. Don't tell them I said that. And that's the nurturing response. The response you get when you look at a young baby when it first smiles to you. You want to look after it, you want to nurture it. And you feel relaxed and you feel good. So that response is the opposite of the fight or flight. And the great breakthrough of understanding that Stephen Porges made was to realize how this was operated through a particular part of the vagal nervous system and its interactions with the means of communication that we have between each other as human beings. So these systems affect how we speak, and they affect what we hear. So if you turn on a threat response in someone, if they feel threatened, they will start speaking in a monotone like this, and they will not look you in the eye, and they will not hear what you say. But if you activate the nurturing response, then they'll be all sing-song again, and they'll be able to look you in the eye, and they'll hear what you say. This is a game changer, I think, in understanding that human communications, the effectiveness of human communication, depends on whether we feel safe or whether we feel threatened. So that little girl probably feels safe, and probably so does her dad. But that lady does not feel safe. She feels threatened. And the communication will depend on this type of response. So here's a cartoon of it. It's about how we perceive our environment, and that will dictate our ability to interact with others. If we feel it's dangerous, then we won't be able to socially engage properly. If we feel it's safe, we will. Now, the question I put to you is, how often do you think our patients, and indeed our healthcare professionals, feel safe when they're in a clinical consultation? Yep, not often. Now, one of the things that makes you feel safe is to be validated. Validation and invalidation are a sort of psychobabble area of research that is an advance on empathy. So validation, you feel validated when you know that the other person understands you and has your best interests at heart. The opposite of that is where you don't feel you've been heard or understood, which of course we hear massively from patients, particularly those complaining about us. And empathy is part of it, but validation is a bit more than empathy because it's about the receiver as well as the giver. It's about whether the other person really feels that you've understood them as much as you trying to understand them. And validation, as I say, does make you, is one of the things that will make you feel safe. It's not the only, there are loads of other things that can make you feel safe or unsafe, but this is one of the things that we can play with relatively easily that will help the feeling of safety. So I guess I've already asked this question. I just got the slide in the wrong place. You know, does that sort of typical consultation story, does that suggest safety and validation? I think not. So some empirical evidence for this. So the hypothesis that another of my PhD students, Maddie Greville and Harris, ran with a little while ago is that validation of another will lead to a sense of safety and a nurturing response, whereas invalidation will be seen as threat, and that this will have the expected results on the autonomic nervous system that Stephen Porges would predict. And it does. And, I missed something there probably. The experiment, first experiment Maddie did was with students in the laboratory doing an impossible maths task and then monitoring the response. So the way that we did this was that Maddie would give them this task and say, you've got 1 minute. It's a very simple task, 1 minute to do this maths task. It was completely impossible. And then when they'd done it, we'd randomized them to 3 groups. One group she didn't give any feedback to at all. She said, well, can you fill these forms in? The group who were randomized to the invalidation feedback, she said, well, goodness me, couldn't you do that? Well, that's a very simple task. I really don't understand why you couldn't do that. And the validation group, she'd say, yeah, look, I'm really sorry. It was impossible, actually. I'm sorry to mess you about that way. It's part of the experiment. No one can do that. So they were either validated or invalidated in their reaction to not being able to do the task, or one group was just given really no feedback, and she tried to stay as neutral as possible with that group. We had one smart ass who did it, actually. That's really quite boring, but you always get a smart ass if you work with students, don't you? So it worked. Basically, it worked. The hypothesis was the data went with the hypothesis. So the autonomic nervous system responses were, as expected, parasympathetic switch on with validation, sympathetic switch on with invalidation. And we did another number of other bits of work around this, including online experiments and some work, rather small amount of work, sadly, directly with clinical encounters and interviews with doctors and their clients. But it all pointed the same direction, and Maddie's published a lot of work on that. But there's one particular bit, I just put this slide in late because Claudia said I might have a few extra minutes to talk than what I'd expected. Is that still true, Claudia? So I just stuck this one slide in and I'm going to talk for endlessly about it. Because the results do support the hypothesis in all ways. However we've done the experiments, if you validate someone, they were able to relax, they felt better, and where we were able to measure it, the autonomic nervous system switch on went in the right sort of direction. And similarly with invalidation, they felt anxious and upset, and they tended to have a sympathetic switch on, a fight or flight type response. But the really interesting thing was that the negative response was much, much more powerful than the positive one. So invalidation was fantastically damaging to people, Validation helped a bit and made them feel a bit better, but it wasn't very effective in changing things, whereas invalidation was quite stunningly bad news. And we think that actually fits with evolutionary theory as well, that because we're better primed for threat than we are for reward in evolutionary terms, our response to threat is an extremely powerful one and an extremely effective one. We sort of calculated roughly on the basis of the data that we have that bad was 5 times more powerful than good. 5 times more powerful than good. And we published that in the American Journal of Medicine last year. Just in case anybody's interested, I'm sure you won't be. But for what it's worth, that's where it is. Again, it fits in with other work in the social sciences about bad being more powerful than good. It fits with work, I think, in the educational field. We have someone in the audience who understands education, but I'm sure she'll put me right. But where the sort of feeling is that you've got to give people a lot more strokes, a lot more rewards for scolding them any one time to counteract the damaging effect of one telling off. You have to do quite a lot of repair work with good stuff. So we are particularly susceptible to threat and to bad things. It's a threat to our identity. It doesn't have to be a physical threat, something that tells you off, tell you you've done the wrong thing, something that threatens us as a person, as an intellect. We're incredibly sensitive to this, and it's incredibly damaging. And I just think this is another crucial issue for the understanding of medicine, actually, and how to practice medicine, because I think we spend a lot of our time activating the nocebo effect by invalidating people or just not getting it right in what we tell them. There's a wonderful Frenchman, the guy who invented underwater birthing. His name's gone out of my head. I'm very old. Could be. Don't think so. Anyway. Yes, Michel Adam. Thank you. Michel Adam. I heard him talking about antenatal care a little while ago. He said, antenatal care? No, we don't do that. We just do antenatal scare. All we do with pregnant ladies is scare the pants off them. Oh, you better do another scan. You never know. It could be, oh, your blood pressure's a wee bit up. Oh, we better watch that twice a day forever. I mean, it's just awful, isn't it? But I don't think antenatal care is any different from most care. We just scare people. No wonder they don't do well. No wonder conventional medicine doesn't work very well. Because all the time we're just scaring people. We are activating the nocebo response extremely effectively, and bad is much more powerful than good. The people who are good at this, getting it the right way around, include really weird people like hypnotherapists, because their training is in how to avoid negative expectations and negative ideas, and how to just work with the positive. And that's what we should learn to do. So I filled a bit of time with that slide. So, if you feel safe and listened to, then you can relax, you can trust another person, you can interact with them properly, and expectations may alter, and you can activate a placebo response as opposed to a nocebo response, which is what I've been rabbiting on about for the last 5 minutes. Or, I think, in light of what I've said, we could call it the caring response. And I'm actually on a little personal campaign at the moment to reconceptualize the placebo response as the caring response. I think it's the response to being cared for. So, placebo or the caring response, and healing finally. So I think I hope I've shown you how caring can facilitate a placebo response. The reason that professor, colleague and patient of mine got better was I cared about him and I cared for him, and I did some things that allowed him to believe that I was trying to get it right for him, and allowed him therefore to be able to change his expectations and the meaning of his illness. And Dan Moorman calls the placebo response the meaning response, but I think, as I say, we should call it the caring response. It may be that changing meaning is one of the effector mechanisms, but I think the thing that stimulates it is caring. And I think healing which is a very strange concept, is at least in part placebo squared, if you see what I mean, or placebo plus, and leads to a massive change that allows reintegration of mind, body and soul to occur. It's always a bit dangerous to say a word like soul in a medical audience, but there we are, I've risked it. So my current work actually with the Institute of Integrative Health in Baltimore is about trying to understand healing. And from quite a lot of work around this, we think that key characteristics of successful healers include focused attention with good intention for the other person, and they're being grounded and able to connect, which is a big subject actually what that means, but we can talk about it in discussion if there's time, otherwise don't worry about it. But what it really means, I think, is that a good healer is showing immense caring for the other person. And the healee, or the person on the other end of it, it's crucial that they feel safe and validated, or in another sense, cared for. And that, I think, allows you to bring these three parts of yourself, which are often rather fractured and fragmented, together in a way that allows you to feel healed or feel whole. So my conclusions are in the 5 issues I've tried to talk about. First, expectations, a complex construct, and crucially, at least in part, a relational one. The joint research on joint replacement shows that expectations matter and can have a huge effect on outcome, but also showed that how we elicit expectations is potentially a real problem. Then I talked about changing expectations and the importance of trust and belief in another person. And then the research on safety and validation suggests that to achieve trust, to therefore be in a position to change expectations, the clinician and client must both feel safe, and the client's experiences must be validated by the clinician. If you want one take-home message in terms of relevance to medicine and medical research, it's number 4, really. And finally, I just self-indulgently talked about placebo as healing as being a sort of squared function of healing, allowing these sort of massive changes in effectively who you are. So thank you very much for listening, and I'm happy to discuss.
We move on to the next presenter. I'd like to introduce Jürgen Barth. Jürgen Barth is the research director at our department. His background is in psychology. And Jürgen will guide us a little bit into research outcomes and the impact of expectation, optimism, and constructs like this on research outcome. Jürgen, please.
Thank you very much. Yes, I entitled my talk Relevance of Expectation, Preferences and Optimism for Treatment Outcome. So we are dealing a little bit with the treatment outcome as well. And the starting point for this talk was this slide here. This is a really huge picture of what all is relevant for expectations. And you see here down there is the expectation, and you see personal characteristics, you see previous experiences, psychosocial cognitive theory, physiological feedback, and a lot of variables are in there. And this huge work of Anne Bowling has about, I think it's 500 pages, and you can read it, but you can also cut it down a little bit. And what I did is I cut it down a little bit. So the initial title does not work. I added health, but nevertheless it doesn't work, so I cut down the information a little bit. So what I'm interested is in the treatment preference, the optimism, the verbal suggestions and their impact on expectations, and at the very end on treatment outcome. So we heard already there are big expectations, big beliefs. We heard already that there are little expectations and little beliefs, and I brought you one item of our questionnaire we developed here in Zurich, and this is read like, I expect that through acupuncture my complaints will disappear, means there is a treatment and there's a clear outcome that my complaints will disappear. So, and it's a personal expectation, which is, in my opinion, the same, like you said, a little belief. And it's not a general belief that I'm convinced that complementary medicine works, or it's not a general belief that I'm responsible for my health. But there's another construct that is optimism, which is in my talk. And in optimism, we have the life orientation test, LOT, and this is one item of this test. And it reads like this: in uncertain times, I usually expect the best. This is more this general one, the general belief. And in uncertain times, it's quite often, and it's a personality trait in psychology. In psychology, you say it is a personality trait, and this might be not able to be changed, whereas these expectations might be possible to be changed. And the last thing is preference. What is preference? You just ask the patient, do you want treatment A, or do you want to be treated by treatment B? That's quite easy. So what does this have to do with expectations and the treatment outcome? Expectations and treatment outcome, there are several cohort studies on patients, and they show mixed results. Mixed results means there are either positive results or null findings. And positive results, there's an association between the expectation and the treatment outcome. So, for example, in the study Claudia was involved, there was a twofold chance to benefit from acupuncture if you are convinced that you have high expectations and you have a positive expectation about the treatment outcome, then you have a twofold chance to benefit from acupuncture. And fortunately, that's a good part, there's no study with a negative effect. No high expectation study ever found a negative expectation and an association of a high expectation and a negative treatment outcome. So you mentioned this quote that maybe high expectations might are also dangerous, but there's no study showing that. Nevertheless, there are some problems. There's no standardized assessment. I mentioned the LOT, Life Orientation Test. This is a kind of a gold standard for optimism. There are other gold standards around, but expectation, there's no gold standard on how to assess expectations. Therefore, it's quite difficult. You mentioned this study using an optimism scale, and you said, oh, it's quite close to expectation, but maybe other people would say, oh no, it's not expectation, it's just optimism. So it's really difficult. We have no standardized assessment. And there are also ceiling effects, meaning people tend, if they go to a specific treatment, to be convinced at the beginning, because otherwise they would not seek this treatment. They would say, okay, I go to another treatment, and so we have a lot of ceiling effects, meaning that people have at the beginning, or patients have at the beginning, very high expectations. And what is also important from these association studies, we assume that this is a linear process. The red arrow shows that there might be an expectation treatment outcome which is completely linear. The higher the expectations get, the better the treatment outcome. But we are not sure about that, if this is really the case. Maybe it is also curvilinear, like the blue one. You have to have at least a minimum of expectation that you can benefit, or if the green one, you have just to be not a denier of the treatment and just say, okay, it doesn't work, then you are already a treatment responder. So we are not sure how this association works, and most studies just assume that it's a linear association in mathematical models. So, and the next problem is there are not only patients' expectations, but also physicians or treatment providers' expectations, as mentioned by the dean, also contribute to the treatment effects. And we did a study where we looked at patients' expectations and we looked at providers' expectations, and we built clusters. And we built clusters, 6 clusters, and looked what happens if we combine their expectations and look, is there an association with the treatment outcome? So, and what we found is on pain, this is a positive response. The larger the higher the effect is, the more response there is given. And you see there's this group and there's this group. This group is called bias. It's called optimist. The physician is optimistic and the patient is optimistic. And here we have a group where the physician is partly optimistic and a part of the study participants, but in some not. But there's a good match overall. Some are in the middle, but also the patient is in the middle. So there's a good match. So they respond very well. But there's a group of, we labeled it as optimistic darters. They say, and this comes back to the belief question, they say, it would work now for me. Acupuncture is a good treatment now for me, but I'm a little bit suspicious if it works in general. So they have doubts in general, and they do not respond very well. So these doubters, and so it's a complex thing that we cannot really assume that it is a linear association, and maybe we have to consider also the expectations of the providers in our model. So let's look at the treatment preference and expectations and the treatment outcome. What do we know about treatment preference? So there's a very early study of the group of Brian Berman, and I just show you this is not treatment preference, but this is a post-hoc treatment guess, and then the people were asked, and the patient were asked, what kind of treatment do you think you received? And there's a true acupuncture group and there's a placebo group, and in the group of the true acupuncture and in the placebo group, a lot of people thought that they received true acupuncture, even if they received the placebo condition. So, and at the end, there was a group, they said, okay, I received the placebo condition, and this was a well matched with here. But overall, 50% said, I have no idea what I have received. Was it placebo or was it a real acupuncture condition? And what is important is, the randomized control trial showed no difference between sham acupuncture and acupuncture. But if you split the sample into those who believed having received acupuncture, they were all responders, and those having not responded said, okay, I have been in the acupuncture group. So the interesting thing is, maybe people changed their beliefs after having received a specific treatment. And the second interesting thing is that randomized controlled trials, maybe this does not take into account these beliefs. And the third important point is, it's a post-treatment guess. What happens if we split up people into their treatment options according to their beliefs, what they really want? And this was done by Claudia in an early study. And she randomized, or she asked the patients, about 12,000 patients, really a huge study, if they want to get randomized and get acupuncture treatment for free, or if they will be not randomized and they have to pay about 10% of the money for the acupuncture by themselves. So they have the choice to get randomized or to get the acupuncture immediately. So this was a decision made by the patients. So, and the idea was to look, are the treatments effects different or are they the same? Because both are allocated to acupuncture. They receive acupuncture, those receive acupuncture. So, and at the end, they showed that the acupuncture versus the control condition, this is here, had a difference on the scale of 22 points, and the difference on the non-randomized, so this non-randomized versus the randomized is only 2.2, so only a 10 times larger effect versus control condition, and the non-randomized control versus the randomized group was only slightly different. Nevertheless, it was significant since it was really a large sample. So this doesn't make really a huge difference, but it makes a little bit of difference. But this has the disadvantage, you compare a treatment A versus a treatment A, and it's not too different. You have not a treatment option. You can either decide, do I want to be randomized or do I not to be randomized? But what happens if treatments are equally effective? So this is a meta-analysis. We did a network meta-analysis, network meta-analysis, a difficult word, on psychotherapy for depression. And you see these plots here, and you can say, okay, it doesn't really matter if you go to a psychodynamic treatment or you go to an IPT therapist. It doesn't really matter. You do not have to understand all those acronyms. The take-home message is it doesn't matter what you do. Okay? So, and then you have the situation that patients would be able to decide, should I go to this kind of treatment or should I go to this kind of treatment? So, and these are preference-based trials, and this is a two-stage randomized controlled trial. And in the first stage, you say, okay, I randomize the patients to either these conditions where patients are randomized to treatment A versus treatment B, or I randomize patients to the group where they can decide if they want to get treatment A or treatment B. So, and the earlier question was, is treatment A equal treatment B or A versus treatment B? But this is not interesting in this context. The more important question is the treatment A, if we give it in a randomized controlled trial, or if it is pre-selected by the patient, equivalent to those here and B versus B here. This is the very important comparison. So, and Swift did a meta-analysis of all available evidence in psychotherapy outcome research, and they found an effect size that it matters about, and the effect size was 0.30, and it matters that if patients self-select their own treatment, then they have a better outcome. And this is quite an impressive thing, because we earlier read these numbers, which are about 0.70, 0.80 as treatment effects, and 0.30 is quite a large magnitude of the effect. So let's have a look at optimism, pessimism, expectation, and treatment outcome. I do not talk about pessimism, even if it would be maybe more powerful, but I like to emphasize the positive way of thinking and looking at expectations on the positive way on treatment outcomes. So, what is optimism? Optimism, according to the definition of Carver and Shire, is an individual difference variable that reflects the extent to which people hold generalized favorable expectancy for their future. That's a sentence only a psychologist can write, read, understand, and reproduce. It's really difficult, but the very important thing is the generalized favorable expectancy. So it's related to our topic, but it's a general thing. So, and optimism improves health and increases treatment effect. So we have better treatment outcomes, we have better stress responses in experiments, lifestyle, etc. This has in numerous studies it has been shown. So the problem is, can pessimists become optimists? If you say it's an individual difference, you say it's straight. You cannot change a pessimist into an optimist. It does not really work. But we heard about positive psychology. So, and one person in positive psychology is Shi King. She developed such interventions to manipulate optimism. Yeah? And this is the best possible self as an intervention strategy, and it's a writing exercise. And in this writing exercise, you get an instruction. Think about your life in your future. Imagine that everything has gone as well as it possibly could. You have worked hard and succeeded at accomplishing all of your life goals. Think of this as the realization of all of your life dreams. Now write about what you imagined. So, and people have to do this exercise sometimes, and there is a short-term effect of mood and optimism and some other health outcomes. And the conclusion overall is optimism can be changed. But does it matter if we change optimism for the treatment effect? That is the next question. So, and this is a study on experimental pain, and they used the same instruction and instructed the students to write a letter of the best possible self or of a typical day. Yeah? And they did a cold pressure test, and those of you who are familiar, they feel pain right now. For those who are not familiar, I will explain shortly. You have a large pardon? A bowl, yeah, thanks. A bowl, a large bowl with ice in there and water, and you put your hand in there. So, and it's really painful. So, and here you see 20 seconds, 40 seconds, 60 seconds. And if you imagine your best possible self, you are doing much better in this task. And if with less pain, and if you have a typical day instruction, you're doing worse. So just imagining and changing optimism in advance of such an experimental stimulus can maybe change as well the pain perception. So this is experimental work. And I think there is more to come, because these are just recent studies, and the disadvantage is optimism has not such a long tradition as other things to do, and the interventions are coming up right now. So verbal suggestions and expectations and treatment outcomes. There's a new meta-analysis of Perriman from the Netherlands, and she looked at all the studies using patient stimuli on pain and looked if verbal suggestions can change the experience of pain. And overall, there was an effect size of 0.75, meaning if you give positive instruction that you can cope with the task, that you can cope, and they have a powerful intervention, you get a drug which is sufficient dealing with your pain, then you can convince people that they experience less pain. So the disadvantage is it's only experimental pain. So can we bring it to a more applied setting, because an effect size of 0.75 is really huge. And just by a verbal suggestion, it is a little bit an overestimation of the clinical routine finding. So there was another study from a group doing the same in acupuncture of the knee, and they looked at the manipulation of expectations by using high expectation instruction, and they gave this instruction to the acupuncturist, and they say, oh, I think this will work for you. I have a lot of success for treating knee pain. Most of my patients get better, and so on and so on. And they were trained to use a high expectation communication style, whatever this means. So they give such instructions in a high expectation way before the patient get the treatment. So, and a neutral expectation group received this information. They said, okay, it may work or not work. It really depends on the patient. We cannot really estimate what happens afterwards. And they get a brochure as well, and the acupuncturists interacted in a neutral style. I would not say it was a frustrating style in a neutral style, but it could be as well a little bit frustrating. So, and what was the effect about over 3 months? There was a significant effect. There was a little bit the problem that there was already an effect at baseline present, and the effect size is of about 0.25, indicating that those in the high expectations group did much better than those in the neutral expectation group. So it brings this number of 0.75 of Perriman a little bit into a more clinical relevant context, that you are able to change by expectations as well pain. To summarize, expectations are connected to the treatment outcome. We would say probably yes. The cohort studies showed us this. In these experimental pain conditions, we showed this as well. The intervention strategy to use expectation, the changing of expectations by verbal suggestions could be a way to improve health outcomes at the end. So I voted probably yes, and it's expectation could not be mediated by expectations. But looking at optimism, optimism is clearly connected to the treatment outcome. A lot of studies showed from Carver and Shire that this is the case. And I also opted for a probably yes here, that it is as possible to use optimism as an intervention strategy, like in this instruction, this writing instruction. It could be helpful. And is it mediated by expectation? I would say yes, because if you give suggestions to write about your best day in your life or a good future, it is always mediated by expectation in your treatment outcome. And a treatment preference, I would say it is connected to treatment outcome, probably yes, or it doesn't matter. And is it an intervention strategy? I think it's not an intervention strategy per se, but it is implemented in healthcare already in the term of shared decision making. If you say, okay, we have different options, which one do you prefer? You have already integrated this in the healthcare system. And is it mediated by expectation? I would definitely say yes, because you activate expectations by asking patients what they really want. So this was this overview. I hope I didn't disappointed that I only selected 3 items of the bowling figure, but I think it was a reasonable decision to cut it a little bit down, the information. Thank you very much.
Thank you very much, Jürgen, especially by showing that the field is much more complex than we sometimes think and that we only know bits and parts of it. Okay, ladies and gentlemen, we are going into the second half of the symposium, and you will see it takes a totally different angle. And it's a great pleasure for me to introduce Jan van der Graef. Jan van der Graef is one of the really knowledgeable systems biologists. He is a professor of analytical biosciences at the University of Leiden, and he is principal investigator and scientist at TNO. And he has done a lot of work in the field of systems biology. And when I asked Jan if he can do something on expectation, he says, oh, that's not really my main area, expectation, but I know that Jan usually, especially coming from the fields of systems biology, always can show an angle which really gives an addition to the field. And you're talking about the human-human interaction and how we can measure this. So join me in welcoming Jan van der Graef.
Well, ladies and gentlemen, it's my great pleasure to be here, and I'd like to thank Claudia very much for inviting me and also seducing me to make this title with lots of words in it. So I added 2 words and I added a question mark so I could sort of manage the expectations a little bit for my presentation. But in order to understand how we develop new methods and how we think, I have to start with giving you an idea about systems biology and about system thinking. And we are very much inspired by nature, and we often look to nature to learn things and apply them in science. As human, we are part of nature, so if you look at nature, you also look into yourself. So that's our approach, and that's why on the first slide you already see an image I made myself. An image, maybe you recognize, is a flock of starlings. And actually it's taken about 4 or 5 years ago in Utrecht, so in the middle of the city and near sunset. So near sunset, starlings group together. You see flocks, small flocks everywhere. They come together and they form one large flock, as you can see over here. It looks like a new animal and it behaves like a new animal. They're not colliding. There's not a boss, so that's probably where it's so nice in harmony. And when you look at it, lots of things has happened. Typically, we refer to these systems as systems of self-organization. And if you like to start, oh, oops, now I did something terrible. I just tried only to use the pointer. I'm back. I'm just, okay, good, I'm back. So, if you look at the starlings and you look at these self-organizing systems and you like to understand something about those systems, then it's getting very important not just to study an individual starling, but to understand the relationship between the starlings and especially how they communicate and how information is shared, because they take decisions. As I said, there's no boss. So connectivity is one of the most important things if you like to understand starling flocks. But it's also one of the most important things if you like to study the human body. How are things connected to each other? You cannot really isolate them into details. You could and you get information, but you need the context to understand what's happening. Now if you look a little bit deeper to this image, you see also expectation very well expressed, because this is a peregrine falcon and he sees 70,000 options for dinner. I mean, this is expectation, I would say. So he sees expectation, but all those starlings are grouped together and it's very difficult to attack those. And they feel quite safe in this type of structure. This unfortunate starling, which you see over there, is a lonely starling flying alone, has not been able to get into the group that will be the dinner of the night. So you see lots of things. But if the peregrine falcon comes, you see also all sort of reactions of the starling group. And you see system response. And system response we will see in health is a very important issue. Maybe health is not a state, but more an ability to adapt. So lots of different things come to us when we look at those self-organizing systems. But they are highly non-linear. They are dynamic. So we're talking about dynamic patterns of relationship, which makes us intrigued about, can we understand more from that perspective if you look at life or at our human body. Having said so, there is an approach, we started around 2000 with that, which is very biochemical oriented. That means if you measure more and more, you will learn more, and that gives you a lot of insights in the human body. So in systems biology, we typically say, okay, we measure all types of molecules, being transcripts or being proteins or small molecules, thousands of them, maybe in just a blood droplet. We put this all together via different statistical methods, and we can look, of course, group of disease, group of healthy, we can find so-called biomarkers, but in fact we're much more interested at differences at the system knowledge. How different are the regulatory mechanisms in the groups? And we learn also that if we study cells, we can understand a lot from cells, but at higher levels of the organization, you get emerging properties which are very important, and you cannot really see or you cannot really measure if you only look at smaller parts. It's a little bit like when you have a car, when you take it apart and you see everything lying over there, and somebody says, could you point to the functionality of driving? That is very difficult. If you put it together, you get some feeling for it. So it's very important to use both, because both have a lot of information. The detail and the context. So what happens if you do this approach? You start to measure. This is, for instance, a project where we measured about 3,000 different concentrations of molecules. It's a study we did with AstraZeneca to look at side effects of their drugs. And you get patterns like this, very complicated patterns, but you can see patterns which are related to the effects, positive effects, or with the side effects, and you get a feeling for it. In fact, this is a correlation network, and there is a line between two of those dots when there's a statistical significant correlation, which make us sort of get the feeling that they are probably close to each other in the biology, because they move in similar ways in the dynamics of those patterns. So important to know if you do this type of work is that we look, as I said, to patterns of self-organization, and very important, there are thinking patterns embodied as physical challenge. So if you get stressed, this system is absolutely changing. what happens if you have other changes in your thinking patterns? What changes are there, and can you find them? This has intrigued us for a very long time, and has also prompted us to look from a slightly different way to these options. But first of all, we have to have some sort of concept of health, as the WHO concept of health as being a state of complete physical, mental, and so forth wellness doesn't work, because there's always something which is missing. Then we would all be ill here in this room, and we all need treatment. So why not use a slightly different concept? A concept in which you see homeostasis between the green lines, you see the system moving up and down, dynamic system. And suppose I come from the Netherlands, which is not I suppose, but that was the fact. I come to Switzerland, and I'm here maybe higher up in the mountains, and my system thinks, there's maybe less oxygen, there's maybe different circumstances. This is a challenge, but I just adapt my set points. This is called allostasis, and I have an adapted system. When I go back to the Netherlands, it's as it was. I go back again, and there might be a point in time that my system loses the ability to regulate myself back, and I might move into a disease state. Where this line is totally arbitrary, typically where people get some sort of symptom they don't like. But you see this development. And if you look at that development, then of course a lot of our drugs and all our medicine is developed in this area, especially by looking at diseases, and with a concept is called one disease, one target, and one drug. That is a concept of one size fits all, or maybe one size fits none, as you like. But it's very important to see that if we are here in an acute case, this is actually quite a very good approach. But it also has effects if you go in this direction. Let us first look at this part, where you have a very serious disease and the concept. Well, if you think about the concept of this part of the curve, the disease management, then it's very much a type of thinking of disease is a war against. Like with penicillin, you have a bacterium coming in, you throw a bomb on the neck, it's antibiotics. And a lot of those things are like we have to stop something. Names are typically anti-this, inhibitors, blockers. So we're very much focused on stopping something, which is very good if you have a very serious case. But what happens if you use this approach also in chronic situation, or you even try to extrapolate to prevention strategies? Well, then if you look at the effects of medicine, when you use them in a much broader sense, it's what you see over here. Here you see the top 10 highest grossing drugs in the US, and what you see are a number of persons, and in blue are the ones which benefit from the treatment, and red the ones which do not benefit from the treatment. And if you look at this, then you see there's room for improvement. And, and in fact, that also prompted us and many others to say, okay, we need personalized medicine. We need to find out which drug fits which person. So we have done a lot of work I will not discuss today, but it's all about seeing differences between individuals. This is very important. But it's not just looking at personalized medicine from that perspective. If you go back into the curve and you say, okay, but if I'm coming here to prevention or in this area, why am I not focusing on health promotion? Because the system has its own way of maintaining health. How can I improve this? How can I promote health? A totally different approach. But how to measure then health? Well, maybe if you change the definition a little bit towards health is more an ability to adapt and self-management in view of all different stimuli, you can look again at system responses. You all probably know the oral glucose tolerance test, which is a simple approach. You take some glucose, you look how the system reacts. But if you start to look not at insulin, but at how the whole system reacts, you get different information. But it's also very crucial that health cannot be seen as separate from the environment. My health state will be very different up in the mountains here as in Holland. So the environment is crucial. And certainly if we start to think later about more the psycho and social elements which are associated with the environment. So this prompted us to have a feeling that we need to measure more and more. But sometimes we also look in the world and say, okay, maybe we find good references by looking at where people are really healthy. But this concept of self-healing in context is something we try to explore. And what we saw in, for instance, the Blue Zone project is a nice project. That's a project which looked around all over the world. And in the Blue Zone project, they found different places. You see them over here. And people get age of 100, but then also at a much better quality of life than elsewhere. So it's interesting to study what is now so important and why is not the Netherlands on the map or why not Zurich here? You start to ask those questions. Well, if you select 4 elements which are very important, which they found to be similar or at least could explain some of those effects, is that people, they move naturally. That means they're not going to the gym and pumping iron all day. No, they have an integrated way of living and working. So they move naturally. They eat differently, but they eat wisely, so they don't overeat a lot. But then the right tribe, the feeling of the right social surroundings, the feeling of trust and security becomes a very important element. And also a right outlook, maybe a right expectation or other words you like to use for that. Whatever your belief is, if you have a strong belief, it appears it helps you to live much longer. Well, this is of course very interesting. So if you want to measure or do interventions, this certainly should be included somehow in the way we look at people and how we can maybe help them. And of course this has been noted by many other people already before, like George Engel. He already said, well, it's very dominant is biomedical. Why can't we extend it more? Why can't we see it more from social, psychological and other behavioral dimensions, health and illness? So people move to biopsychosocial model, and today we also add all sort of spiritual elements to it. And that brought us for a difficult first question. The first question is, if you are so good in measuring, like things like this correlation network, how can you find differences, phenotypic differences between people, so you can do this more personalized health and personalized medicine approach? And how can you find also the other dimensions which are important for determining the dynamics of these regulatory mechanisms? Well, that's why I often find myself in 2 different phenotypes. The one is here who have just done the measurements, which is very proud to have beautiful measurements. And the other phenotype when somebody from the audience asks me, what can you do with it? So here is a challenge. What can you do with these difficult structures? And we looked to other types of knowledge in order to calibrate our systems in phenotyping. If you take the life complexity pyramid as a start, you see here in the bottom all sort of molecules, and if you go higher in the regulatory status, you see here metabolic pathways, functional modules, maybe organ-organ interaction, large-scale organizations. And what most of us are doing is measuring a lot, trying to figure out how they link together, do all those complexity biology, network biology, and try to come here or even there. But there are other aspects of medicine worldwide which come from the other end. For instance, Chinese medicine is very much a type of medicine which is not looking at the details but describes systems from a phenomenological perspective, and that has been a start of having a look whether we could combine the two in what is called the Sino-Dutch Center for Preventive and Personalized Medicine. Can we use Western diagnosis, for instance, to look at diabetes? Can we use subtyping from Chinese medicine and then look with our system biology whether we could validate those subtypes? And it's not the topic of today, so I will not say a lot, but if you are interested, you could read the article you find over here, in which we explain that if you want to develop good interventions, you must be sure that the diagnosis is right. So you need to have a very good diagnosis. And what is very interesting from Chinese medicine, that they describe the system from what you see over here, so-called the inner landscape, where they explain how the body works from a contextual perspective, and they explain why certain symptoms are related and how the dynamics of systems are. It's very interesting, and a lot is also known in Western medicine if you start to look from that perspective. So that's why we use this graph you find on the cover also, where you see in the inner side the Tai Chi symbol, and you find the Vitruvian Man of Da Vinci also looked of man in perspective, and you see system biology and the inner landscape together. And we came to the conclusion that there's a very good match, and we showed that for different diseases. So this is nice, but we still said, okay, if we don't get a good diagnosis, we can't monitoring what we're doing, we can't make a step forward. And we showed that for different elements. I will not go into detail. This is another article where you see the complex life pyramid over here. And here you see, for instance, from angina pectoris, how you see in yellow the symptoms which we know from more Western medicine, a lot of other symptoms which are used in Chinese medicine, and you see there come other elements which relate very much to who you are, how your anxiety is, how your discomfort is, and it starts to give you a different view. And we did quite some studies in this area, looking at different indications. For instance, this indication, which has been used by more than 100 million people, showing that if you did some sort of pharmacology, you find all sort of elements which are involved, but especially you found some sort of regulatory mechanism which has to do with the muscle modality, why you could see why heart muscle and your lower back pain, why they relate with each other, and sort of things came up which nowadays again are found by other studies. So we had the opportunity to add things like this to get more other types of elements into the diagnosis. But we still had one very important other question, and that's actually the question and the results I like to share today, which is, okay, could we measure if a system is in coherence? Could we measure that somebody feels happy? And could we feel or measure that somebody is happy or getting happier when he meets somebody else, or that he gets less happier when he meets somebody? In other words, is there any clue that we could measure this? That has been a question for a while, and I'd just like to share with you what we can do today. And for that, I just ask you to go back into nature for a second and listen to the following.
As dusk gives way to twilight, the encroaching darkness is lit by life. These dancing lights around me are produced by fireflies, creatures that have the strange ability to produce light. They bioluminesce. And fireflies are not alone. Scientists are finding ever more strange and wonderful glowing life forms all around the world. Living light has always fascinated me, and the discovery of more and more luminous creatures raises more and more questions. Why? What is the light for? And how is it made? In recent years, scientists have begun to find answers to those questions. And in doing so, they've taken us into a world that is utterly unlike our own. However astonishing these images look, they are all real. With help from new cameras, one designed just for this film, we can reveal this extraordinary phenomenon as it has never been seen before.
isn't it? If you noticed how the fireflies start to work together, you saw self-organization working. But if you study bioluminescence, it's not just only creatures in the deep sea or the fireflies, which are so well known. If you study and look at literature, you will find that every organism, every cell emits light. Also, you are emitting light. And this is very unique in both, wavelengths, timing, rhythms, and so forth. So we're emitting light, but at a very low level. And it's interesting to see whether we could measure that and use that as a new diagnostic insight. And without going all to details, but it's long ago, 1923, when Gurewitz showed bioluminescence and communications in onion roots. And this work has been developed further, also in other countries, and it has been used for disease diagnosis. People start to understand the biochemical background, which is typically reactive oxygen species which are formed, into imaging, into self-organizing systems, and you can understand this is where we are heading for. So in this area, I started to work together with Roel and Eduard van Wijk, and they did a lot of work here, pioneering work in this area, and we started to see, can we look from a self-organizing system? Well, actually, this is Roel, one of the pioneers, and here you see a very nice image of him in the dark room, because the light intensity is extremely low. That means you have to work in a dark room, and the light intensity is a little bit like a candle at 30 kilometers distance. But you can do that with biophysical measurements, and you can see that the body emits light, and it emits light on different spots. And you can measure that, and of course you can measure different things. You can measure the amount of light, but you can also measure what we call the photon dynamics. That means you look at how the photons come from your body, for instance, by measuring your left and your right hand, and you start to relate the two. And it appears that if you have a very strong relationship between your left and your right hand, that you are getting close to more a harmony or a coherence. And what we did, we looked at healthy people, and I will not go into detail, but you see distribution here, pre-diabetes and diabetes, you see all sorts of differences. We could also relate these parameters to the subtyping we found in Chinese medicine. So it gave us a lot of feeling about, hey, we can measure dynamics, we can see the differences, maybe we get a totally new diagnostic tool. We have a couple of PhD theses coming out early next year, but I'd like to share with you some other results which are more in line with what we're discussing today. For instance, stress reduction and health. You can measure different techniques and look at people who do this type of meditation, see whether you can find differences when they do these experiments. So what we do, we have here, you see a dark room, and you have a person there. This is all isolated, and you have cameras which can measure on different spots. Of course, we know the biochemistry changes during meditation, but we like to have a non-invasive type of technology. So we measured 60 subjects. You see them over here divided in other meditation techniques, TM and control subjects. And what we found is that's a lower emission for the TM, OTM group. Some people think that you start to radiate more when you meditate, but in fact the body is much more efficient with energy when you meditate, so you emit less light. And the overall photon emission, so the intensity was much lower in the different meditation groups. Also, we're investigating in more depth these photon distributions. You also see a lot of effects. But somehow the emission patterns over all those points are very identical per person, but there are a huge variation between the different subjects. So that's very interesting result. What's also very interesting is that if you study paramecia, which you find at least in Holland everywhere in fresh water, probably also here, this experiment from Daniel Vels is very interesting. He had paramecia in a closed container and another container over here. When there's nothing in between, this paramecia, the growth rate is as they were together, because they influence each other. The growth rate is determined by the number of paramecia. If you put a visible light filter in between, they behave like isolated groups. That means that the visible light, what we measure, indeed also helps to do the communication between the two groups. And now lots of people are interested in communication and the type of communication we haven't seen before. And Roel and Eduard did a very nice experiment, I think, which we will extend even more, that he looked at the interaction of two humans, in this case a patient and a healer, and they did intentional healing, but then in alternating periods, if you see over here, they did the measurements, but not on the people, but on algae, which were also in the room. And you see that the algae start to oscillate with light differently when there is a non-treatment or a treatment period. So we do feel there must be some sort of communication. We still don't know exactly how it works, but it's also very reproducible. So maybe this human-human interaction could be measured at one point in time. At least we are getting in the area. And this is just something I like to share because we also like to communicate nice things. If you measure hands and you do it in the way that you connect the instrument to different symbols over here and you transform the light into frequencies which you can play over here so you get music out, you can start to listen to your own body. And in the museum, Boijmans van Beuningen, we had this set up. You could go in there in the dark room, put your hands in there, and then listen to your own music. So you can listen to yourself, and I remember that first thing I was trying to influence it, but that's not so easy, I can tell you. So we do a lot of those recordings, and we try to see what is the sort of basic patterns for people, and what can you influence, and are they influenced when you get very stressed or something else. So there's lots of things, and I like to close more or less with our types of observations at this point in time, which are that if you are in an interaction between, say, a patient and a healthcare provider, there's lots of things which are happening. We heard of it in a lot today. We look at the patient, we describe them in a way that we take into account all those different levels, family, culture, spatial positions and so on. But this interaction seems to be very important. And I must say, I also know that from myself as a patient. I've been in many hospitals, also in hospitals where I had a lot of fear. And then suddenly you open the door and you see a doctor who cares about you. And you forget about the hospital and you feel very good. So I think we all sort of realize, and I think it was also very nicely emphasized today, that if you meet somebody and you have a real contact, this is sort of the basis for very good healthcare system. So compassion is very important, and all those variables have been mentioned. In green, I emphasized once more that if you look at placebos or just the effect of human-human interrelationship at a very high quality, that's an effect that really cares for your health. And by saying so, I hope that we start to feel more like the study from Otto Scharmer shows. And he did some investigations in Germany, and I asked people, how do you what sort of level of treatment did you got and what do you really want? And then patients and physicians said, well, due to all sort of healthcare limits in time and whatever, it's a sort of repair visit. You come in, you say, complain, you say, okay, this is it, and you go out. But most people actually want to go deeper. Unfortunately, their people are very good, so they can give more therapy or reflection and so forth. And in fact, lots of the healthcare systems worldwide are trying to reduce the intuition and reduce the knowledge of the physicians, while this is the most important aspect, I think, of the healthcare system. But it's very nice if you ask them here in white what you really want. In fact, what they want, they have an issue in their lives and they want to get better or to change their lives. So they're more interested in self-transformation. And maybe the physician becomes more a midwife in such a case. You let the patient move her or himself towards a new position, but you help where you can, and you're not going to dictate what they have to do. So I feel that this is a way of thinking about our future healthcare system. It means that we move, at least in the Netherlands, very much from focus on production to, okay, let's measure your outcome. But we do a lot of measurements which do not really reflect what we are looking for. So maybe we should move forward and try to get more human-oriented care, very much driven by compassion for each other. And in a way, of course, people always like to measure something to have a feeling it works or it doesn't work, especially politics. So we do a lot in trying to develop those methods, at least to give directions towards development of certain systems. So I very much hope that it will work, and you're doing fantastic work. So Claudia, also very happy you have this very nice research group, because I think it's the utmost important to move forward. And then I conclude with some remarks, and maybe I should explain to you also about expectations with this slide. This, in fact, is a slide that was taken in Rome just before New Year, and it just happened I was sitting and reading the newspaper, and I saw there's enormous annoyance in Rome. There were too many starlings, everything was white and whatever. And I looked at my wife and I said, okay, let's go to Rome. And there we had the opportunity to see between 1 and 2 million starlings. And we had a fantastic show. This is called the KISS, this image, because it reflects the interaction we're looking for. And it means that we move, in my opinion, from reductionism more to context thinking, to systems biology. We move from disease thinking to much more personalized thinking, health and wellness. And I think it's reflected in the words, because I is in illness, it's more the isolated case, and it's more to do with relationships like we, as we see in the word of wellness. Thank you very much.
Okay. It's now a great pleasure for me to announce Stephen Wolf. He just came in this afternoon from Washington. So I assume it's a very busy time for people in public health at the moment in the United States.
Yes.
Many political meetings at the moment. And Stephen is really in the middle of this. He is professor for family medicine at the Virginia Commonwealth University in Virginia, and is a director of the Center of Health and Society, or Society and Health? Perhaps Society and Health. And Stephen will put expectation now for us very much into practice. These are some of the research studies he is doing, and here it's really about patients' expectations about cancer screening. So welcome, Stephen Wolf.
I'm really, thank you. I thank you, Claudia, for inviting me. I really appreciate the opportunity to come to Zurich and to be here in Switzerland. Normally that would always be a treat, but it's especially a treat right now to help me escape from my country for a few days. It's a very strange place. It normally is a strange place, but now it's a really strange place. So, and I am directly coming from the airport, so when I think about expectations, my body's expectation is to be in bed right now, so forgive me. This is a very hard act to follow. I think the presentations that we've heard this afternoon are fascinating to me, and I think there's a level of sophistication and complexity to what we've heard this afternoon that makes me feel that this talk is really very simplistic by comparison. But Claudia asked me to talk about it, so here I am. In our country, and perhaps in other European countries, but it's definitely the case in the United States, there is a relatively simplistic attitude about patients' approach to complex decisions. There are guidelines that dictate what types of treatments people ought to get based on various parameters, age, gender, risk factors, and so forth. and rather simplistic approaches to how people should make those choices. Typically in the consultation between the doctor and the patient, it happens in a single consultation or office visit, as we call it. In our country, averaging about 10 or 15 minutes for a typical primary care consultation. The patient is told what particular treatment is recommended or what treatment options should be considered. An attempt is made to provide information about those choices, and presumably a decision is made. And we all know that's not really how the process ought to be, or frankly how it actually happens. Certainly for complex choices, patients need time to educate themselves about the condition that they're being treated for, learn about the different options, and go through what we call a decision journey to figure out for themselves which choice is best. But we really don't know very much about what that decision journey looks like. And this is a very rudimentary study that we did to try to begin to start looking at this. The complex decisions we were looking at for this study are around cancer screening, but really this could apply to any kind of a complex decision. So first, acknowledging lots of co-investigators that helped with this project. And let me just begin with the problem. I've already summarized a lot of this, but one point I want to emphasize is that we have traditionally thought of the process of helping patients to think through these decisions around the clinical encounter as the focus of where that happens. And we are probably entering an era where we need to escape from that paradigm and think about the larger process that patients are going through in making decisions and figure out where the clinical encounter fits into that, rather than trying to in the medical model, think of it through the lens of what happens during the clinical encounter. So the project that I'm telling you about was funded by an agency in the United States called PCORI. It was a 2-year project. The specific aims are laid out there. The idea was to try to reach patients outside the clinical setting rather than waiting for them to show up for an office visit. Identify patients who were eligible for cancer screening, then begin to understand the process they go through in thinking about their choices. And rather than doing it the right way, the way most people in this room would probably want to go about understanding how patients are going through this process, we used a very simplistic method, which is to take advantage of a portal connected to an electronic medical record. Now, I believe when I mentioned this to Claudia, she said that portals are not commonly used here in Switzerland. Do any of you recognize that term, portal? Okay, so let me just explain what that is. In the United States, a lot of doctors have switched over to electronic medical records rather than paper records. So the clinical providers, the doctors, the hospitals, are all connected through these electronic systems. But increasingly, they're trying to make that system accessible to patients. So patients can make use of a portal, which is a web-based site that they can go to look into their clinical record. And it's typically pretty limited at this stage. So you can look at your lab results, you can see some summaries of your office visits, you might be able to see your x-rays, you may be able to communicate with the doctor, send questions, or schedule appointments. We took advantage of a portal like this to do something much more proactive, which is to reach out to a population of patients that we identified and try to develop an interface for them to try to understand how they go about the process. So if I can get the pointer to work here. The idea here was this portal, which they are normally using already, would identify people who were potentially eligible for cancer screening. I'll explain what that means in a second. And then have them answer a series of questions. And based on how they respond to those questions, give them customized information about the choices that they have available. That gives them an opportunity to do research on the decision-making process. And then some of what they end up concluding can then get passed on to the clinician, who at the time of the consultation can be aware of that information ahead of time And some of this is basic information. Some of it would fall under the category of expectations. What are the patient's expectations? What are their concerns? What are their fears and worries? We actually did audio recordings of those visits so that we could see whether the visits changed. And then we had post-encounter surveys completed by the patient and the clinician afterwards. So we had data coming from various sources for this. So this is what the portal looks like. So typically, if you were a patient, you'd go to this to find out. This is oriented around preventive services, meaning screening tests, health promotion activities, immunizations, and so forth. But you see, you can look up different information about yourself. But if you fell within one of those three categories of eligibility, and those three categories were men over age 50 who were potentially eligible for prostate cancer screening, women over age 40 who were potentially eligible for breast cancer screening through mammography, and men and women over age 50 who are potentially eligible for colon cancer screening. We identified all three of these because they're controversial, at least in the United States, as to whether that kind of screening should be done. And if you fell into that category, this prompt would appear that would invite you to complete this portal or this module called My Questions was the name given to it. But it's a series of questions that basically are meant to try to understand where the patient is coming from. So the first screen that you would see would look something like this, in this case about colon cancer screening, saying you have a decision to make about colon cancer screening, give you some background about the information, and then hit you with a series of these 17 questions, beginning with how far along are you with making the choice. All 17 of the questions are shown on this slide if you want to get an idea of the kinds of questions that we were asking at. But what you'll see here is not only an attempt to try to understand where in the decision journey people are in thinking about this process, but to try to get a sense of what their key questions are, how they go about getting information, what ways they like to see their information organized. On the issue Paul raised, what kind of fears or worries do they have? What are the types of steps they want to take next? This is, in our view, basic descriptive information about how people go about making decisions. There's not a whole lot of data on it. There's a lot of limitations to these data that I'll tell you about, but it was an attempt to try to dip into that topic area and try to get more information about it. There is a question that patients come to at this point where they ask whether you want to discuss this the next time you visit your doctor. And if they say yes, the electronic system automatically forwarded the answers to their questions to the electronic medical record of their doctor. So a summary of their answers to these questions then arrives to the doctor so that when the doctor next sees the patient, they have that information in front of them. We began with a relatively large sample of patients who answered this. You can see their demographic characteristics here. And what I'm showing you are some of the data that began to come back from this study. So first of all, that first question about have they ever heard about the screening, you see this is a population that is generally more knowledgeable about the screening test. This study was done in a location in the United States with a relatively educated and knowledgeable patient population. If we'd done it in other parts of the country, that would not have been the case. Many of them had heard that they should be screened, and most of them had heard about this from their doctor, but they had heard about it to some extent from other sources. And then we began to try to unpack where they are in the decision journey. And this is what the images on the screen typically look like. So in terms of understanding how far people were in making the decision, again, this is a population that had already been thinking about this. But wanting to understand, what's the next step that they take after they begin thinking about this? This is showing the distribution of their answers by type of screening: breast cancer screening, colon cancer screening, prostate cancer screening. A tendency for most of them to want to talk to the healthcare provider, but what we saw was that the men who were thinking about prostate cancer screening seemed more dependent on needing to talk to the doctor, had more questions, more uncertainties, which actually is pretty appropriate given the lack of evidence on that particular kind of screening. They answered questions that, as I mentioned, were directed at trying to understand what kinds of information was most important to them. What were the key questions that they wanted to answer? And they also had questions that asked them, ask them to describe how they like to get their information. Do they like to get it as pictures? Do they like to see numbers? Do they like to see videos? And depending on how they answer those questions, this system customized the resources that were put together for them. So for example, in this particular example, these were the 4 leading questions that the patient had identified, this particular patient. What are my options for getting screened? What are the health benefits of screening? What are the problems? And what are the costs and insurance coverage, a big issue in my country. And so these 4 boxes would not necessarily appear when you completed the survey because you might identify a different set of questions. But also when you click on that button for that particular question, the way the information is presented was customized to reflect what you said you wanted the information, in what format you wanted the information presented. So in this particular case where the patient said they like to see the information visually, an infographic like this was presented. They gave them a sense of perspective about the magnitude of benefit, similar to an infographic that was shown in the earlier presentation. They could at any time go into a library of resources that are available on this site. So you can see here for any variety of questions that they might have that we had resources in all these different types of categories depending on how they like to see their information presented. Again, trying to understand, well, what are the next steps that you take in making this decision? This is an attempt to try to get some descriptive information about what choices they feel they have made. In the case of colon cancer screening, what kind of test they would like to get, and then what next steps they'd like to take. Whether they want to talk to the doctor, talk to family, etc. As I mentioned, we tried to get information about what questions were most important to them. Here you can see the questions that seem to be the most important up at the top. But you'll notice that women facing breast cancer screening tended to be a little more overconfident about what they needed to know. So you'll see a pattern here in terms of how they differed from men who were considering prostate cancer screening. On the emotional side, in terms of fears or worries, we tried to get a sense of what the leading concerns were that people had in terms of anxieties about screening, and you can see those listed here. Again, we also use this study as an opportunity to learn more about where people go to get information. In this case, you can see a fair amount of dependence on web-based information. We tried to get a better sense of how people's cognitive process worked. These are not the kind of advanced psychological studies that we've heard about earlier this afternoon. This is simply people's self-perception of how they go about making these decisions as answered on a survey. Nonetheless, to the extent that that's relevant, we saw that there was a large proportion of patients who felt that they made the decision by going through a cognitive process of weighing benefits and harms and deciding which treatment was best. In terms of confidence in the decision, a strong tendency for women considering breast cancer screening to feel like they knew what they needed to do. This is perhaps an American phenomenon. There's a tremendous cultural sense in my country that mammography is very effective and very important and a standard of care that actually is inconsistent with the randomized evidence from randomized controlled trials. And you can sort of see it played out here in these data. Limitations. There's a bunch of limitations listed here that are the kinds of traditional concerns you would hear mentioned in a health services research presentation. They have to do with issues of sampling, the metrics that were used for the study, the generalizability of the results, and so forth. But there's another kind of limitation that I think bears mentioning at a conference like this, is that it lacks the kind of nuanced contextual understanding that we are talking about in this session. So if we think about complexity, systems thinking, as we've been discussing this afternoon, and the very contextual nature of how people make choices, that any one of those hundreds of patients that were in this study, each were going through their own decision journey. So a population-oriented survey like this really can't get into that level of nuance. Paul said we have to embrace complexity. Study designs like this are really not appropriate for dealing with that kind of level of complexity. Nonetheless, in terms of what conclusions come from this study, it looked like most patients did want help in finalizing their decision. It makes sense to think that people's attitudes and expectations about, in this case, cancer screening or potentially other complex decisions do depend on where people are in their decision journey. It seemed like a lot of people wanted to go about this process by weighing benefits and harms. I personally am not convinced that that's really how people make decisions, that they sit down with the mathematics and figure out what the effect sizes are and weigh it. In this study, American men eligible for prostate cancer screening seem less confident in screening than women who were thinking about mammography. And information technology, I think, can be helpful in reaching out to people, but we went into the study realizing that this is a very poor surrogate, a computer, for the kind of nuanced analysis of how people make decisions that's really needed. So I'll stop there. Thank you.